Thought I'd do a quick video on some of the contraindications to the administration of neuraxial anesthesia. So when we're talking neuraxial anesthesia, remember we're talking about both spinals and epidurals. Now, we can do a whole other series of videos on what the differences between these are, but the essential difference is this is going into the subarachnoid or intrathecal space, same place that you get CSF, and this is going into the epidural space, so it's outside of the dura, so it's not actually going into the meningeal layers of the spinal cord. But the contraindications are more or less the same. So starting off our list, and you'd be surprised at how often you run into this, is actually patient refusal. There are a number of patients who actually don't like the idea of getting a needle in their back, and it scares them. So if they're really worried about it and you can't convince them, then that's a contraindication to giving that type of anesthesia. And you can think about causes of increased intracranial pressure. So this is situations like trauma settings. If there's a suspicion of a head injury, then you shouldn't be doing any kind of spinal or epidural anesthesia, because if you were to poke into the subarachnoid space and there's increased intracranial pressure, you can get brain herniation, which obviously we don't want. That's also a contraindication for lumbar puncture in the emergency room, which you've probably heard of as well. Then we can talk about coagulopathies. Now, these are contraindicated because if you were to cause some bleeding in and around the spinal cord, you can cause what's called a spinal hematoma, which, if there's difficulty clotting, can get very large and cause spinal cord compression, and causing various distal neuropathies, which obviously we don't want. So that's a contraindication as well. Now we can talk about fixed cardiac output states. And the reason, and also severe hypovolemia, and we can talk about that more in a second, volemia. Now, fixed cardiac output states, this is things like aortic stenosis, mitral stenosis, Hockham, and the reason that these are contraindicated is because the cardiac output itself is fixed, and what that means is when you get one of the main physiologic effects of spinal and epidural anesthesia is severe vasodilation and hypotension caused by the actual local anesthetic. When it's going in, has a preference to knock off sympathetic fibers, and so you get an unbalanced parasympathetic versus sympathetic, and as a result you get hypotension and vasodilation. And in these fixed cardiac output states, like aortic stenosis, like mitral stenosis, like Hockham, you get situations in which the heart cannot compensate by increasing the cardiac output to compensate for the vasodilation and hypotension that's caused by the local anesthesia. And so in situations like aortic stenosis, you can imagine where not only does that compromise the blood flow to the end organs like the brain, like the kidneys, like the liver, but it also can compromise the blood flow to the endocardium of the heart. So, for example, in the example of aortic stenosis, over a long time you get the development of a dilated left ventricle with a thickened wall, and as we know from our basic physiology, the endocardium is supplied by the diastolic pressure. So if you and with a thickened wall, you need a higher diastolic pressure to cause perfusion of that thick wall. So in a situation where you have a drop in the diastolic pressure, like you would when you give a spinal anesthesia or an epidural anesthesia, you end up with a situation where the endocardial blood supply or blood flow is compromised. And so these are very dangerous situations in which to give spinal or neuraxial anesthesia. And in other causes of severe hypovolemia, so like sepsis or just, a general hemorrhage, you would imagine the same thing. The body doesn't have, or the heart doesn't have the volume or the preload it needs to compensate for the hypotension and vasodilation. So it can't increase cardiac output to compensate for that, and you get potential compromise of end organ blood flow. And I mean, you wouldn't think that you'd be in a rush to put in a spinal or an epidural, in a trauma situation or where there's lots of bleeding or something like that. But septic pictures come along fairly often. You can think about bowel obstructions or perforated hollow viscus, where if the general surgeon is going to go in and do a laparotomy, that it would be very helpful to have a long-acting epidural in place. So that's just a simple overview of the major contraindications to neuraxial anesthesia. Thanks for watching.